to recognize faces, you lose the ability to read, you lose the ability to function in a lot of ways. It's very sensitive. Can you go forward? You want me to push it? I'll tell you what, so that we don't interrupt, if I can just say next slide, I think it'll be much better. Okay? I'm not sure it'll work. I think we're better off just saying next slide. Okay, can you push to the next slide? Good, and to the next slide. Okay. And push one more. And push one more. Now this shows you one of the main problems from diabetes, and that is having high blood sugar levels causes blood vessels to leak fluid. You can see that because we injected a food coloring dye here. It's fluorescein. And it's leaking out of the blood vessels between the left-hand slide taken 30 seconds after we injected the fluorescein in an arm vein, and then 5 minutes later, you can see the fluorescein leaking out there. Next slide. And this shows you a cross-section of the retina where it has swollen in the center. And if you leave that swelling alone, that swelling, like a dry sponge filling with water, eventually causes destruction to the retina tissue. And this process is called diabetic macular edema. Diabetic because it's from diabetes, macula because it occurs in the center of the retina, that light-sensitive part that we need to read, and edema because it's swollen. Next slide. And then if you can get rid of that edema before the retina has lost a lot of tissue, you might be able to prevent the person from losing more vision, or you might even get some vision back. Next slide. Now, we typically measure the effect of edema by seeing how far someone can read on an eye chart. Ideally, they can read all the way to the bottom line. Next slide. And this would be the 20/20 line. Next slide. But if you have some edema, you might lose the ability to see anything other than larger letters. They have to be bigger. Perhaps your 20/40. Next slide. And this means that it's getting more difficult to drive and read. Next slide. Now, what can happen as you go down this chart, next slide, is you can actually continue to lose vision from edema. Push again. Next slide. And it can get down to 20/80 where you probably can no longer drive. You might be able to read headlines in a newspaper. Next slide. And if it gets all the way down to perhaps the bottom of the chart, next slide, down to about, next slide, 2200. At that point, you probably are considered legally blind if this has affected both eyes. Next slide. And so we try to prevent this from happening by identifying when somebody has this swelling or diabetic macular edema. Next slide. And next. Now, what happens if you get down to 2200 is you cannot see in the center anymore, and you can't use your side vision to see around that, or you can't recognize faces either. Next slide. And so what we want to do is prevent people from getting to this level of vision by identifying who has this diabetes, who with the diabetes has the swelling, and then treat the swelling. Next slide. And next. We learned a few years ago that there are certain growth factors that are produced in the retina tissue when diabetes damages the blood vessels from high blood sugar levels. So diabetes causes high blood sugar levels. This damages the retina blood vessels and the retina tissue, and they pour out these growth factors. Next slide. And one of these growth factors is called vascular endothelial growth factor, which causes blood vessels to leak, and that's what causes the swelling or the macular edema. Next slide. And so what we'd like to do is figure out how can we get rid of these factors that cause the swelling. Next slide. And one thing we could do is put in anti-growth factors that are antibodies that literally mop up those factors that cause the swelling. Next slide. And when this was identified about 10 years ago, several investigators went to Congress and said, we have this huge problem with diabetes, and we have more people than you realize that are going to have this problem, and we would like you to support and provide some funding to allow us to collaborate with all of our colleagues in the United States and have a network that could take lots of different ideas and rapidly test them within a year of the idea to determine if that will work at getting rid of these damaging factors. Next slide. And so this DRCR network was designed to be a very efficient way of testing treatments that we would invite the entire retina community in the United States to participate in. Next slide. And in fact, as of last week, there were 119 sites involving about 360 ophthalmologists around the United States. This represented 1/3 of every retina practice in the United States is participating in this. Now, it's not every person in each practice, but we have broad representation there, and there's about 1,000 other people working on this. Next slide. And the idea was to rapidly do protocols, and this just shows you the active ones that were going on, labeled A through R, to try and stamp out the problems from diabetes. Next slide. And there are 5 of them that are actually ongoing right now where we are still recruiting people and still doing the follow-up, and those others on the previous slide are ones that we've completed. Next slide. And a lot of this has been published, but like JAMA Network, they're not all published in JAMA Ophthalmology, but they are all available for free, as are most of these slides, because the network helped put many of these together if you just go on the web at drcr.net, because we want to make sure this is available to the world. Next slide. And in fact, all the data are available. So once we complete a study, we deposit the data online for free, and if there are other investigators that have other ideas of what to do with this around the world, there it is for them to work on. And we've had about 1,200 people download the data to do this. Now, it's not something you could download and easily analyze by yourself with an Excel file, but with a good biostatistician. We've had industry and investigators and university people around the world use these data to help identify other ways of trying to treat diabetic retinopathy. Next slide. And we've had collaboration with industry. We don't have the drugs to test this. We have to go to the industry and we say, we'd like you to give us the drugs that we may want to test. This could otherwise cost the government tens of millions of dollars to be able to do this. But we go to the industry and say, it's only if the network can have complete control. And industry may not want to do that, but we've convinced enough of them that it's in their best interest, and we've had wonderful collaborations in 11 studies so far. So what I'm going to concentrate on, next slide, is one example from the network to show you how we're getting close, but we still have a long way to go. Next slide. This protocol looked at comparing laser, next slide, which did cause improvement in vision, as shown on this slide, so that these are people in this trial who were given laser, and they, on average, had improvement in vision from their diabetic macular edema. Next slide. But we found that if we use an injectable drug to get rid of those growth factors, and it's an antibody to those growth factors, you could triple the improvement that was seen with laser. And that was whether we combined the drug with laser or used the drug alone. Next slide. We had tried another drug as well, corticosteroids. It didn't work quite as well because it had more side effects. Next slide. And it's true on these bottom 2 curves here in yellow and purple, those are steroids or laser, that you got improvement. That's 30% of the people improving. Next slide. But 50% improved with the growth factor antibodies. And it's not just how many people you can improve. The idea is catch these people before they lose vision. Next slide. Because only these drugs, next slide, leads to fewer than 5% losing any vision. The lines on top here in purple and yellow, that's with laser alone or laser with steroids. Unfortunately, those cause some loss in 15 or 20% of the people, but the injectable drugs, less than 5%. Lose any vision over 2 years, and now we've shown at least to 3 years. And hopefully by the end of this year, we'll have 5-year data to know if we've really halted this problem. So that's why, we've come so far. Now, that drug, or 2 of those drugs, are very expensive on either side here. The one on the left is aflibercept. The one on the right is ranibizumab. There's a very inexpensive drug, bevacizumab, but it's not made by the company to go into the eye. And the question is, okay, now you have a way of treating it, but you can't necessarily use that around the world. Would something less expensive work as well? And if not, how well does it work? And so the network's doing a trial now that will be out likely by the end of this year to tell us how these 3 compare. Now, finally, we're not too good at getting people who need this treatment from coming in. This shows you the prevalence of people that have diabetes in the United States based on a survey over the age of 40. Based on a good survey done by the CDC, it was about 20 million people in 2008. Next slide. And of those 20 million people, about 14 million have no diabetic retinopathy yet and have no macular edema. So we want to find them and say, make sure someone monitors you for this problem. Next slide. But about 5 million actually have some damage of diabetic retinopathy, but they don't have the swelling yet. They have no diabetic macular edema. We want to find those people and say, you already have some damage. Let's make sure we follow you each year and figure out if you get this edema. Next slide. But finally, there's about 840,000 people in the United States that have diabetic macular edema, a condition we now can treat. So we can treat it. So we looked at this survey and we said, how many of these people, and we just published this online 3 months ago, we said, how many of them know they have it? Because we can treat it. We would think it's solved. Next slide. So we looked at these people and we asked them 3 questions. Next slide. We said, have you been told by a doctor that diabetes has affected your eyes? When was the last time you saw a diabetes nurse educator or dietitian? When was the last time you had an eye exam in which the pupils were dilated? This would have made you temporally sensitive to light. And we had photographs on all these people, because some of them knew they had diabetes, some of them didn't. Some of them knew they had diabetic macular edema, some of them didn't. Next slide. And what we found, if you look on the left-hand side, in green are the people who have diabetic macular edema, the disease we can treat, and 45% of them said, yes, a doctor's told me that diabetes is affecting my eyes. But look at the right-hand side of this graph. 55% of the people who have diabetic macular edema were not told by a doctor that they have damage in their eyes from diabetes. So this is where we are so far. I suspect it's a worldwide problem. This is the first survey that's been done like this. We want to replicate it and see what our problems are around the world. Next slide. And we asked them, when's the last time you had a dilated eye exam? Look on the right-hand side. Those are the people with diabetic macular edema. 40% of them say it's been more than a year, and in the article we tell you that for half of them it's been never that they've had a dilated exam. But we found in this population survey, it's a good representation of the United States, that about 40% of them do not know that they have this damage in the back of their eye, nor have they had a dilated exam to find it. Next slide. So that's why I share this lecture with you today, to celebrate and to challenge. So the celebration is we're really close. We have now figured out ways. They're expensive. They're time-consuming. We'll figure out ways of getting it less expensive. We'll figure out ways of getting it less time-consuming. But we're still far away. Why? Because half of the people in the world don't know they have diabetes. And even people that know they have diabetes may have something we can treat and have no idea that it's going on. So we've got to figure out, the next step is how can we identify them, and how will we be able to reach out and stop a lot of this vision impairment and blindness, because I've told you that's a huge problem. And if they come in after they've gone blind, it's very hard, if not impossible, to reverse it. And so we have treatments that we can use now, and we're so close, but still far away. Thank you for letting me share that.
Thank you, Dr. Bressler. That was very enlightening. I think awareness is part of the most important part of the problem.